Right, good evening, everyone. Let me share my screen. Can everyone see my screen?
Yes,
Yeah.
thank you,
Right.
Dr. Sonubi.
Right. Good evening, everyone. Once again, Dr. Sonubi. I'm a GP registrar somewhere in Daventry, and today we'll be talking about weight management and obesity. I want to apologize. My voice might sound a bit croaky, and I might be coughing a lot because I still have been flu this afternoon, so I feel a bit poorly, but I'm okay otherwise. Just I might not sound as good as I would like to. Okay, so bear with me. So our objectives today are to talk about safe and sustainable weight loss, setting weight loss targets, making healthier food choices, exercise plans, and prevention of weight regain. In terms of introduction, some of the things I want to talk about. So I'm just going to move this up because it's covering my right. Sorry, it was covering my slides. In terms of introduction, what is obesity? Why is it an important topic of discussion? How do we differentiate between underweight, normal weight, overweight, and obesity? And what are the other parameters that we have to measure? Please feel free to stop me at any time. I can't see anybody's face anymore because I've hidden the thumbnail. And in terms of definition of obesity, I've highlighted some things that I want us to take that I feel like is quite important. And that's the fact that obesity can be defined as a complex, progressive, and relapsing chronic disease. It's characterized by abnormal and excessive body fat that impairs health. So I think it's important we keep in mind that it's complex, so it's not straightforward. It's progressive, is relapsing, and is a chronic disease. I'm not sure if worldwide it's been agreed to put obesity on the list of chronic disease, because I don't see the medical community actually treating it as one. Though in recent times things are beginning to change, but if we look at what's available in terms of treatment, in terms of medications and help that is available, I don't think it's given as much weight as things like diabetes or hypertension, and it's really on the same level with them. And the fact that it impairs health means that we should be doing more about it than we're currently doing. I just want us to know that it is not merely a lifestyle choice. It's not just that somebody chooses to be obese. It's not that someone just feels, oh, if I make bad choices, I could just be obese or I could stop being obese. And the statement, just stop eating, is not really an helpful statement, because it doesn't stop the obesity, because it's progressive, it's relapsing. And when someone that is obese is being told, if you just stop eating, you stop being obese, it is not helpful in any ways. And this slide shows us the health complications of obesity. If you can see that obesity practically affects every organ. In the brain, it can cause hypertension, it can cause headaches rather, which can show as idiopathic intracranial hypertension, which really presents as a form of headache. It can cause stroke in terms of plaques can line the vessels that pass blood around the brain. And if these plaques fall off and block the arteries, it can cause stroke. It can affect the eyes in form of cataract, can affect the heart by causing heart attack. It can have diabetes, hypertension. It predisposes to cancer of the breast, of the uterus, of the neck of the womb, of the food pipe, which is the esophagus, of the pancreas. It affects the skin. Sorry about that. Affects the skin. It affects joints by presenting as osteoarthritis. For a lot of women, they can present with what we call polycystic ovarian syndrome, in which they have irregular menstrual periods. And for some people, they find it difficult to have to get pregnant. It can affect sleep. It can cause obstructive sleep apnea, in which people have episodes in which they cease breathing while sleeping. So as we can see, it basically affects almost every organ in the body. And the question then is, why is more not being done for this if it's doing so much? In terms of how do we calculate, how do we categorize people's weight, whether they are underweight, they have elderly weight, overweight, or obese, we usually use what we call the BMI. And this is calculated by finding the person's weight in kilograms and dividing that by the square of their height, which is measured in meters. There are lots of online calculators that are available. And if you go to the nhs.uk website, you can find the BMI calculator. And what we have is healthy weight is when the BMI is between 18.5 and 24.9. I want to point out the fact that for our community, for people of Black, Asian, minority communities, our LD weight is a little bit lower than this. So it's mostly from about 18.5 to about 23. Anything above 23 starts flagging that we're at higher risk of diabetes, of hypertension, all of the other complications we've said already. And then overweight starts from 25 to 29.9. And obesity starts from 30. There are more classifications of obesity, but it doesn't really matter here. What's important is once the BMI is above 30, then it's classified as obesity. Apart from using the BMI, we can also use the waist circumference. And when we use both the BMI and the waist circumference together, it gives us a better picture of how the fat distribution might be causing more complications for the individual. So when we measure the waist circumference, if in a male, if it's above 94 centimeters, there's an increased risk of obesity-related complications. And if it's above 102, there's even much more increased risk. And in the female, it's 80 and 88 centimeters. And waist circumference tells us a bit more about fat distribution around the waist. And it's that fat distribution around the waist that causes even much more problems than fat distribution in other places. Now, talking about some of the causes and risk factors of obesity. If you remember earlier, I've said it's a complex issue. It's not just about lifestyle, although lifestyle plays a huge factor in it, but there are other risk factors in terms of genetics. We do inherit different kinds of genes, and people inherit genes that predispose them to not realizing they are full, because we have hormones that tell our brains that, oh, we've had enough food, we can stop eating now. And we have what we tell our brain that we are hungry and we need to have more food. And if there's not a right balance between these hormones, we can continue having more food despite the fact that we are actually physically full. So genetics plays a lot of factors in that. And we do have medical conditions as well. So for someone that has issues with their thyroid, if somebody's hypothyroid, they are likely to be on the spectrum of being overweight or obese compared to someone that is hyperthyroid, because hypothyroidism will make them burn more calories. And other conditions like depression can also increase somebody's likelihood of eating more. Medications as well, especially when it comes to antipsychotics that are used in the treatment of some psychiatric conditions, can actually make somebody to have lots more food. When we're talking about lifestyle factors, things like the consumption of food, the kind of drinks we take in, the level of physical inactivity, and it's been estimated about on the average, we spend 7 hours at least being physically inactive, either by just sitting on the couch, by watching TV, by resting, looking at stuff on our screens, or spent in public transport or driving around. And then there are social and psychological factors, such as family gatherings. What do we do when we gather together? what kind of food do we tend to eat in our family setup. And there are other factors as well, like age. As we gradually increase in age, we tend to pile on more body fat and have less lean muscles. With menopause, there's also predisposition to increase body weight. Socioeconomic factors has a big role to play, in the sense that one, healthy food is a bit more expensive than readily available food that is not as healthy, which means the people that do not have enough to spend on food will most likely be eating more unhealthy food. Then sleep deprivation, sleep and weight loss work hand in hand. The worse the sleep is, the more difficult it is to lose weight. There are some other factors that drive weight gain. Right, so if somebody already has excess weight and they're on the obesity spectrum, the fact that they feel stigmatized, which is a real thing that happens even amongst the medical profession, there's a lot of unconscious bias towards people that are overweight or obese. Sometimes you tend to see them and you're wondering, can they not do better with themselves? Are they happy with the way they look? And that stigmatization, the fact that they can feel people treating them differently, just makes them not want to access medical care when they are supposed to be doing so. It just drives, it can lead to low mood and depression, and that just makes things worse. Also, the misconceptions. Hello, can you hear me?
Yes, I can. Can I just ask you, did you say the more you sleep, the more weight you gain?
Sorry, I meant the less you sleep. Did I say that?
The less you sleep, the more you gain.
Because when you're not sleeping well enough, your stress hormone is increased, and the stress hormone is gonna make you want to have more food.
Right.
Does that make sense? So a good night's sleep, a well-rested body, it's much easier for that body to lose weight than one that is sleeping, say, 4 hours, 5 hours, constantly being stressed.
Yeah, but if you sort of, don't need a lot of sleep anyway, but you're not stressed, does that work the same way? Because I know Margaret Thatcher, for instance, they said she only used to sleep for 4 hours a night, and she certainly wasn't overweight.
Well, it's so at the end of the day, it's a complex thing. So we can have genetics, what people actually consume. Like if somebody is not sleeping much, but they are not actually even consuming enough calories, they are probably not going to gain weight. But for someone that has already gained weight and they are not sleeping well, it's just counterproductive. I don't know. At least I know by science and personally, whenever I'm struggling with stress, it just makes it difficult to control what I put in my mouth, because all I can think of is anything goes. I just want food. I just want to feel okay. And cortisol is the stress hormone. Once the cortisol level is reaching the roof, it just makes it makes it difficult to actually work on the weight loss.
Okay,
does that make sense at all?
Yes, it does. Thank you.
That's all right. So I'm just gonna hide this again because it's covering my screen. Okay. Right, so I was saying that there's a misconception that when people lose weight and they regain it all back again, it's a result of lack of willpower or motivation to adhere to lifestyle changes, but that is not true. If you remember earlier, I said it's a chronic relapsing condition, and there are reasons, there are biological reasons for that. It means you lose weight, there's a high chance, the probability of gaining it all back is very high. If we think about the fact that other chronic diseases, for instance, if we pick diabetes, when we start treating diabetes with medication and the blood sugar level comes down, do we stop treating it? The answer is no. We continue to give medication to maintain the blood sugar at the level in which we want. And sometimes things spike up, and then we have to go back to the drawing table and ask ourselves, what is not going well? What should we do differently? And the question is, why would we see obesity as different from that? It's a chronic disease. There are other things that drive it apart from lifestyle. So it's the fact that someone has lost weight and gained it all back. It's not just about lack of willpower, lack of motivation to lifestyle changes. It's much more complex than that. And if the medical community can take that on board, the way we treat people will be a bit much different than what we are doing currently. And it's a well-known fact that maintenance of weight loss is actually a far greater challenge than actually losing the weight itself. If you go on a crash diet right now and you go on a very low calorie diet, you can lose a lot of weight in 1 week, 2 weeks, but actually keeping that weight off is actually much more difficult than losing it in the first place. And as I was saying, the part of the complexity around obesity and weight loss is what we call the body weight set point. Now, in about when we are in our late teens to early adult, we get to a particular level of adipose tissue store in our body, and the body knows this is what it wants to keep, and it does everything possible to get back to that same kind of adipose tissue store. So that's what we call the body weight set point. If you think of the fact that if someone gives blood, and let's say the hemoglobin is say 130, gives blood today, so definitely the blood level will drop. In about 3 months' time, the blood level goes right about the same thing it was just before the blood donation was done. And that's what the body keeping is hemoglobin store. Is a tightly regulated system. And it does the same for our sodium level, our calcium level. It does the same for our adipose tissue level. So if somebody has been obese around their late teens to early adults, we should be expecting that they are going to be fighting a battle for the rest of their life because their body wants to keep itself around that. So they lose weight and they gradually start piling up, and they probably get to where they were before, and they lose it again, and it starts happening. So it's just going round about in circles. Now, that doesn't stop us from trying. So some people will say, so why bother then? We still have to bother because, like we said, there are a lot of complications associated with being overweight, being obese. And I missed the point of there's also what we call the body being tightly regulating itself such that it prevents a starvation environment. And this is a bit important when somebody has reached a plateau in their weight loss. So the body wants to have a level of energy intake that matches its output. And if this level is not enough, the body slows everything down. So the normal things that would happen just in the background, everything starts getting slowed down because the body wants to defend itself. So the body is not expending any extra energy doing anything because it's perceiving that there's a starvation going on. And as soon as you have any extra, you just start storing it as fat. So it just shows that it's a bit more complex. It's not just a straightforward, or if you just keep dropping off your calorie intake, you're gonna lose weight. Now that's to talk about what obesity is and why it's difficult to lose weight, but we still can. So now we should talk about safe and sustainable weight loss. How can we lose weight safely? Now, the most important bit about losing weight is calorie reduction. So how much do our body actually need, and how much are we taking in? And for the most part, we're actually eating way more than our body actually needs. And how can we do this without going through the science of it all? There's a way to calculate how much energy our body needs daily and how much you should be taking, but I won't go into all of that. Just some things we can do that's very easy on the surface. If we bulk up our meals with fruits and vegetables. Why? Because vegetables especially are quite low in calories, and they would add as much to the energy level of what we are taking as compared to if you have a plate full of rice and fried plantain. I don't know if that includes some of what we eat. Also being mindful of liquid calories. Now, fruit juice is lovely, is really nice. But if you actually look at the content, the calorie content of most fruit juices, you realize that 1 cup can be about, say, 70 calories or 80 calories. And having 2-3 cups while sitting down is almost half or 1/3 of what a meal should contain. And then the smoothies, everything that is liquid calories, just be mindful. Now, people can have Diet Coke and all of the 0-calorie ones, which in terms of weight loss will be much more better. Portion size is another thing that can help in terms of weight loss. So just reducing the portion of what you normally have, which can be done by using a smaller plate. So instead of using a regular dinner plate, you can use a smaller plate. And just the fact that the food is not all in front of you might be an encouragement not to have everything at once. Also trying things like having water before the meal, having water whilst having the meal, and water at the end. Filling up with water takes some space in the stomach, and then that reduces what actually goes in terms of food. Healthier food options. So in our world of today, we have a lot of things that is flashed in our face that is actually not as healthy. So trying to substitute what is not healthy for something healthier can be an opportunity for us to lose weight more sustainably without actually trying too hard. In terms of cooking methods, we all know frying adds a ton of extra calories to whatever it is that we're having. An alternative to frying is grilling the food, or for those that are able to, using an air fryer, which you just need a little bit of oil and it cooks the food fast. For some people, there's taste difference, but at the end of the day, we get used to the new taste. So trying healthier cooking options, it's a way of trying to lose weight without doing too much. Now, in terms of crash diets, they have their benefits, but they do a lot more harm than good. In terms of benefits, if somebody has a plan, let's say there's a 6-month plan or a 3-month plan, and the person wants to start with 1 or 2 weeks of crash diet and then quickly move on to a more sustainable plan, that can be quite helpful because it kickstarts the metabolism, it kickstarts the psychological part of losing weight, but there has to be a follow-on plan. But a crash diet by itself or a long-term crash diet doesn't really help. It just backfires. So most people that go on very low-calorie diet, they lose a lot of weight whilst they're on the diet. But once the diet is over, that's it comes back on, and it comes back on real bad. So we want to either use it wisely and safely or avoid crash diets entirely. And the fact that while somebody is on a crash diet, they also crave the food they love, they miss all the food they love. And once the diet is over, they just want to go back to everything they've missed. It just makes it really bad as well. Now, there's a lot of talk about intermittent fasting on social media. Intermittent fasting will work if it's being done in, I would say, with calorie reduction in mind. So if there's let's assume there's a window of eating from, say, let's say 12 in the afternoon to about 6 in the evening. And the person doing the intermittent fasting is only having 2 meals a day with a lot of fruits and vegetable, mostly water in terms of liquids, and reduced portion sizes. That might keep the calorie intake within the allowed that allow the person to lose weight. But if somebody has a 12 to a 6 p.m. window, and in that time it's breakfast, lunch, dinner, snack 1, snack 2, snack 3, it doesn't actually make any difference. So it's not really, what I'm trying to say, it's not the timing of the meals. It's mostly about what goes into the mouth at the end of the day. So whether it's spread out throughout the day in terms of 6 very small meals, or you have just 1 large meal, at the end of the day, it's the calorie content, is what is actually going in that matters. Now, to set weight loss targets, we want to set sensible, reasonable targets that are achievable. So we want them to be specific, to be measurable, to be achievable, to be realistic, and to be time bound. And that is one of the ways we can actually have safe and sustainable weight loss. So now I've written some goals and example objectives. So let's, for instance, say you want to increase physical fitness. An example is being able to walk to the bus stop within 6 weeks. For somebody else, it might be being able to run a marathon. It might be being able to do a gentle jog for 30 minutes without stopping for breath. Increase water intake. A lot of people might struggle with water intake. I, for instance, in the last 1 year, I've really struggled with drinking plain water. So a goal for me might be drink 2 liters of water daily within 3 months. And for me, that will be plain water. Maybe there can be fruits in it, but no tea, no coffee, no sweeteners. For somebody else, it could be to reduce cardiometabolic risk factors. The objective might be decrease waist circumference to 85 centimeters within 3 months. You might want to include 2 portions of fruit and vegetables per day. The actual recommendation is 5 portions of fruit and vegetable every day. For someone, their goal is to improve quality of life, and that might be maybe to wear bikini by the following summer, maybe to be able to take the grandchildren out for lunch. Whatever the objective is, it should be smart so that it can be measurable, is realistic, not expecting too much within the time frame that has been planned for. Now, I just want to talk a little bit about making healthier food choices. On social media, you see a lot of good food, bad food. I don't think there's, apart from some food that on the surface, there's really nothing really good about them. Most food can, they're being good or they're being bad is based on the situation, on how we feel, on our pocket size. It's not just a straightforward, easy thing. So for instance, now, having burger, for some people, that is bad food. But it all depends. If you're having burger, say once in a week, once in 2 weeks, that might not actually be so bad in itself because it might be satisfying some craving and keeping the desire to have it every day at bay. Or for somebody else, it might mean that they are making it themselves at home and they've substituted the bun, they've added extra nutrients in it to make the bread more nutritious. They've made their beef patty or whatever it by themselves, and it has more nutrients than it should really do. So what I mean really is there's really no good food, no bad food. Avocado is very good source of fat, but it's quite high in calorie. Now, for someone that's trying to lose weight, the person might want to limit the quantity of avocado they have in their meals, but that doesn't make it a bad food. Not things like groundnut, cashew nut, all forms of nuts. They are good food, but they're also very high in calories. So there's really no straightforward good food or bad food. Everything is about the balance and having all the nutrients as well. It doesn't make sense to be having plain vegetables that doesn't keep one full in the name of good food. So it should be a balance. We should be having things that will supply us energy, will give us good fat, will give us vitamins and nutrients all at the same time, so the body doesn't feel starved. Now, we've talked about portion sizes already. We've talked about cooking techniques that can make the food retain its nutrients without adding extra calories to it. We've talked about including vegetables and fruits in each meals, drinking more water, reducing liquid calories. Also, increasing fiber content is quite important. One of the reasons being it helps to keep us full for much longer. So if, so for instance, white bread doesn't have as much fiber as wheat bread. So by having a mixture of the two without losing on taste, one might be able to increase fiber content, including things like nuts in one's meal in good quantity would increase fiber as well. And we also need to have protein in our meals. Those are the things that make us feel full for much longer, rather than just having, so for instance, making a breakfast. Just a cup of cereal with milk might not keep one as full long enough as having maybe a smaller cup of cereal with milk, with some fruits that is high in fiber, and with a side of protein, which can be egg, which can be chicken or something. In terms of eating out, I mean, there are different tricks people have tried to make healthier food choices when it comes to eating out. One can check out the calorie content of the food in the particular restaurant before going out, so you have an idea of what exactly you want to take. When it comes to having salads in restaurants, for the most part, the dressing is very high in calorie for most of the restaurants. So telling them to take away the dressing, to not add it to it, might mean halving or just drastically reducing the calories that come with the salad. Trying to have bigger portions of protein can also be helpful, and having a smaller portion of food, one doesn't have to finish the food on the plate. Yes, you've spent good money on the food, but it doesn't all have to go into the stomach. Those things can be helpful. Now, exercise has loads of benefits. Of course, one of the benefits of doing exercise is to help in weight loss. And one of the ways it helps in weight loss is to increase the lean muscle mass. Now, when the lean muscle mass is increased, like for instance, now I don't know if a lot of ladies have wondered why their male colleagues or their male partners seem to not gain weight as fast as the female. Part of the reason is because they have more lean muscle mass than females. And the muscle burns extra energy just in the background. 70% of our energy expenditure is what happens in the background, just sitting down, really not doing much, because our body, every single cell needs energy to do their function. So the lean muscle mass also burns energy in the background, and the more muscle we have, the more energy we burn in the background. So doing exercise really helps with that as well. Also, it makes us feel good. It boosts the mood. It's been said that it helps to release the feel-good hormones, which are things that you just, I don't know if you've tried doing exercise when you are really not feeling it before. And when you finish, you feel really better in yourself and like, yeah, I've done a good job in myself today. I have felt like that. It also improves flexibility. It improves skin tone. It improves sleep quality. It boosts self-esteem. And it's been said to reduce the risk of stress, of depression, of dementia, and Alzheimer's disease as well. Now, in terms of what kind of exercise can we do? NICE has advised that we do at least 150 minutes of moderate intensity exercise over the course of 1 week. And it could be 75 minutes of vigorous intensity exercise. And what do they mean by moderate intensity exercise? We want the heart rate to go up. We want you to feel just a little bit out of breath. And if it's vigorous intensity, not being able to complete 2 sentences without having to pause. Now, there are cardio exercise. Well, you do things like running, walking, jogging, have strength training exercise, and it's recommended to do both as much as possible. More strength training exercise would actually build the lean muscle mass. It's been said the cardio exercise can help lose the calories right there and there. But the strength training, because you're building muscles, you seem to keep dropping to be burning calories in the background over the course of the day. Flexibility exercise like yoga, like Pilates also helps. Now, where can you do this exercise? Going to the gym can be helpful, but that might not be possible for some people. Joining exercise groups, joining walking groups, or joining exercise classes in the gym can also be helpful. One of the things I've found quite helpful in recent time is doing my exercise at home, which you can either do by having a home gym, but that might be out of range for a lot of people. A lot of exercises on YouTube where you don't need any equipment at all you need is just yourself. If you go on YouTube, you find loads of exercise that one can do. And especially for those that will struggle to go to the gym, maybe because of childcare, because of distance or whatever, that might actually really be helpful. Now, how do we prevent weight regain? Earlier on, we talked about body weight set points. And the reason why I brought this back is for us to be mindful of the fact that weight regain is a definite consequence of being overweight or being obese. For some people, they will be very lucky, they will never regain weight, but they're actually in the minority. For most people that have been on the overweight, obese spectrum, almost at one point or the other, they're going to regain the weight they've lost, and they're going to start the journey all over again. So being psychologically ready for that actually does help. Instead of when it happens, the person starts feeling really bad and does not know what to do again. Also adjusting for holidays, for festivities, for special occasions. We're going to be having Christmas soon, and it means there's going to be a lot of chocolate, a lot of cake, a lot of good, bad eating, whatever we want to call it. So just allowing for those things, allowing for enjoyable things, instead of saying no. For someone that likes chocolates, instead of saying no chocolates forever, having it within the plan that one has. So if, let's say, you have a 1,400 calorie plan for the day, have the chocolates that can still fit into that plan and allow you to actually enjoy the things you do. Then we said earlier to avoid crash diet, especially long-term crash diet, because it's just going to bounce back and the weight will probably come back on again. And just to be mindful of the fact that weight regained can be lost again. It's not a gloomy picture. Everything can be put back into gear and made to work again. Also, to praise oneself for the weight loss achieved. So if you've lost 5% of your body weight, wow, that's a good job. It's not everybody that can lose 5% of their body weight. Remembering that maintenance of weight loss is a far greater challenge than losing the weight itself. We already mentioned the fact that understanding that relapse is an expected consequence of managing a chronic condition. The fact that somebody regains the weight they've lost is just an expected consequence of obesity. We should not see it as the person is not trying hard enough. It should be seen as part of the normal process. We should take pleasure in improvements in health parameters as well. So losing weight, apart from the fact that it makes us look good, it makes us feel good, it does a lot more as well, preventing the complications, reducing blood pressure. For some people, their blood sugar goes down. They might not need medications anymore. It reduces the cholesterol, reduces the risk factor of having stroke, of having heart attack. Those are good things that we can take pleasure in. Also, how else can we prevent weight regain? If something is not working, to revisit the weight management approach and ask, why is it not working? What can we do to change it? Am I having a very restrictive diet plan that is not making me actually enjoy the things I love? How can I incorporate all the things I love over the course of the week, over the course of the month? What do I move around? What do I change? Why is it not working? And taking a pause and assessing the challenges and setbacks and thinking of strategies to overcome them. And if possible, set completely new and achievable goals. So if losing 10% of body weight in 3 months, it's a bit too much, why not set it to losing 5% of the body weight in 6 months instead? So now, apart from the lifestyle modifications, which we spent a lot of time talking about, it's just to talk about what else is available. So we have some medications that are available, and also surgeries available based on the degree of obesity. The reason why I'm not going to spend so much time talking about these is because the even if we're using medications, even if we're using surgery, lifestyle modifications, lifestyle changes still form the bedrock of weight loss, weight management, and losing weight is what is still going to keep the weight off rather than every other thing. Now, for some people, just at what level of obesity they have would determine what should be made available for them. So in terms of medication, basically we have just two medications that have been licensed in the UK. We have Orlistat and we have liraglutide. Orlistat can be prescribed at the level of the GPs, but unfortunately it's not available to prescribe in every area of the country. So if somebody needs Orlistat, so for instance, their BMI is greater than 27 and they have comorbidities or is greater than 30, they should be eligible to have Orlistat prescribed on the NHS. But that might not be possible in some areas. And in terms of liraglutide, the criteria is a little bit higher than for Orlistat. The BMI, yeah.
Sorry, what's that word that you're saying? Orlistat.
Orlistat, I will just type it in the chat.
Yes, please. Thank you.
Orlistat. And the second one is liraglutide. Now, the liraglutide is not available to be prescribed by the GPs as of this time. If a patient needs liraglutide, they have to be referred to secondary care. But if part of the problem is enough people are not being referred actually, based on many different factors, and there are not enough weight management services in the secondary care. But if somebody feels they need liraglutide, they should still be referred on. If the BMI is over 35 and they have diabetes or any comorbidities like hypertension, they should be referred on. And anyone with a BMI greater than 40 should be considered for surgery. And as we can see on this chart, if the BMI is greater than 35 and the person is Asian, they should also be considered for surgery. But I don't think enough is being done medically, but these are the other things that are available for consideration. So in summary, we've said, overweight and obesity, they are associated with multiple health complications. There's early mortality, there's reduced quality of life, and there's a lot we can do. And just realizing the fact that even 5 to 10% of body weight reduction does a lot to significantly improve health outcome. It can reduce risk in terms of diabetes, can reduce risk in terms of hypertension, it can improve quality of life, and not enough is being done. And I really do hope that we can do much more as healthcare professionals for patients. And these are some of the references I've looked up. Right. And I think I would like to open the floor for questions, discussion.
Doc, I put my question in the chat. I don't know if you
Yeah.
saw it. And my name is Joanne, not far from you in Northampton.
Right.
And my questions are I have two questions. So the first one is, how do you determine the daily calorific needs to lose weight sustainably? Because in my case, you talked about the yo-yoing. Like, I can decide and I will do it. All those things you've said. Go to the gym, reduce my calorie intake, and what I mean. Like, I know these things. Does it make sense? Like, when you're talking about the fried plantain, I was laughing because that's one of my favorite things. But when I decide it's gone, it's gone, right?
Yeah.
However, even with knowing these things, I still feel like in my case is another level. And when you talked about all this start and all these things, such options have never been availed to me, to be honest. Like, I've never been told that this is an option. And for me, particularly where I'm so happy, I don't even know how I ended up in this chat, in this Zoom room, but God knows, is because a lot of the obesity things that you've mentioned, I what's the word I want to use? They just seem to just spring upon you, if that's the word. Like, One day I go to the GP and I'm told you're pre-diabetic. The next day I go and I'm told that you need to get onto metformin. And I'm like, can I change my lifestyle? I'm going to go to the gym. All those things that you've said. Then I do those things and the thing comes a little bit down. And then life happens. The weight goes up. You go and you're told your HB1C is high. Okay, now we're going to put you on metformin whether you like it or not. You know what I mean? Then the next thing you're told your cholesterol is high. We're going to put you on a statin. And I'm talking, this is it's not a story. It's my story. So what I want to hear from you, because I feel you are very empathetic and very kind about this journey, is how do I determine, like, what are my daily calorific requirements? Because I believe that's not something that is standard for everybody. You know what I mean? Like, my age, there's so many predetermining factors, and then how can I reverse some of these? Because I'm talking about these statins and all these things that have been given, were literally given to me last week. So I'm fresh, like I'm a week 1 in metformin, and I don't want these things. You know what I mean? And then the last question I asked you there is the mindset, because it's so easy to be like, okay, now I'm on this medication, I might just as well like surrender to it. That's not my portion. I refuse it. I'm not going to accept it. That's not for me. But how do I do that while still doing what the doctors require of me? Am I making sense? Or I've said too many things?
Yes. You're making absolute sense, and I'm really sorry to hear about everything you've been going through. And
Thank
it
you.
does, yeah, I'm really sorry. It fits into most of what I've said, most of what seems to happen to a lot of people. It just seems to cascade, and more of the complication, and it just seems like an never-ending
and sorry, by the way, doc, I'm not sedentary at all. I go to the gym 5 times a week. So that's another thing. What do you call it? Like a judgment that people have, that you're an overweight person, you're lazy or whatever. I go to the gym I do my cardio, I do my weights. Like, when it comes to those things, I don't play. You're talking about the Pilates, you're talking about the HIITs, high intense. I do all those things. However, the weight is still an issue.
Right. I do totally understand what you're saying. And in my personal journey of losing weight, doing crash diet, doing lots of gym, what I've found that has been most sustainable when I've actually lost weight and kept it off is the calorie reduction, keeping the calorie within what my body actually needs. And so it's something most of the time we miss, and we do more exercise. And if you look at it, if I remember the numbers correctly, if you run on the treadmill for about 30 minutes, I think you lose about 300 calories. That's just roughly about 2 big fat bread slices. So if you sit down and have 4 bread slices with peanut butter, you've cancelled all the gym work you've just literally done, if you get what I mean.
Yes.
Now your question about how to calculate your daily calorific needs.
Correct.
I do apologize. I don't have the numbers or the equation with me, but I can write them up and send to Anne, and she can send them across.
I don't know. This was put in our WhatsApp group, so I don't even know how I ended up here. So even when you tell me Anne, I don't know who Anne is.
Oh, I see.
I'm also unwell, doc, so I'll probably just put my email address and the Anne can send it to me.
Yeah, that's fine.
Thank you.
Thank you for that. Also, I'll send it across to Anne, and then she can send it across to you. Because just to remember as well that as you lose weight, your daily calorific needs changes as well. So if we get to a point where you plateaued in your weight loss, it's just to remember, maybe I need to go back to the drawing board and check again, am I within my daily needs? Because the calculation will be based on weight, based on activity level, and all of that. Does that make sense?
Absolutely, and I've put in the chat for Anne my email address. But how do you get this? Like, do I go to my GP? I'm New Northampton. Like, I just joined my GP. Do I just go and say, "Hi, doc, whoever, can I get Orlistat?" Or is that like, do I just ask?
Yes.
Like, how does it work?
I think you should just ask. You can ask your GP that you've heard about Orlistat, you've heard about liraglutide. You want to find out if you're eligible for it. And
Okay.
I cannot promise you that they will say yes, because I work in Daventry and I'm not allowed to prescribe Orlistat, which is really a shame. And if I were to be working in where in rugby, I'll be able to prescribe Orlistat. So it's a bit based on the funding of the CCG as well. That's
Okay.
what, yeah. So you can ask. The worst you're gonna get is a no.
Yeah. Okay. And
then
it's
you
not
got,
something I can order. You can't
so
you can't go to the counter over the booths. No,
so
it's not there.
Orlistat is available over the counter, but it's a lower dose compared to what can be prescribed. So a prescription, it should come as 120 milligrams, and it ideally should be taken with a fatty meal. So the idea of the Orlistat is to kind of prevent your body from absorbing the fatty food from the meal. So you're just gonna have like a watery, loose stool. So if you're going to keep off fatty meals completely, then Orlistat might not be useful actually. So it's like it's a funny medicine in that sense, and that's probably why not many people are too really keen about it. But over the counter is available. It's going to be a bit
less
more
dosage.
expensive. Yes, at a less dosage, and it's a bit more expensive.
I mean, when it's coming to where I am, price does not matter right now. It reaches a point where the cost is not the issue. It's getting the thing down. You know what I mean?
Yeah, I do get.
Yeah, because I really want to get this. I don't want this metformin beyond this. Well, I've just started on. I don't want it to be in my life, and I completely believe that these things can be reversed.
Yeah.
So it's really finding the solution that is for me and sticking with it. So, and I believe that God will just give me that wisdom. I don't know. Yeah.
I mean,
thank you.
In terms of food plans, I've not been. There were not things I wanted to put on my slides. So I have a couple of people, because I'm Nigerian by origin, and I have a couple of people that have developed meal plans that are suited to the Nigerian palate that I can say I've used, and I have people that have used, and they do work. It might not be something the whole group might want, and they've not paid me to advertise for them. They have no idea I'm saying it, but because it's worked for me in the past, I mean, I still use their meal plans. It helps to put my head in a good frame of you're having too much oil, because I can literally fry my egg with just half a teaspoon of oil, and it tastes as good to me. I can't even stand fried egg dipping in oil. I can cook my pot of stew with just 1 teaspoon of oil, and it tastes as good to me. So it's all those changing in the cooking habits that can make a lot of difference. So if anybody wants, I can give the name of those food plans.
Yes.
Okay, I'll just type it in the chat section.
Yes, please
so
do.
They've not paid me for adverts. I have no link to them. They don't know me personally.
It's
so
okay.
If you go to Google and search for Lose It Nigerian, that is one. Sorry, I've put it in caps lock. It's all in.
Yeah, it's I can see it. Lose It Nigerian.
And the other one that I know of is sorry, my caps lock is on. Optimum Foodie. There are other ones. This is the two that I have had actual interaction and experience with.
Thank you very much. This is really helpful, because I mean, ethnic food is ethnic. I mean, I'm Kenyan. I'm originally from Kenya.
Doctor, we have somebody who's raised their hand. They'd like to speak now. Would that be okay?
Yes. Yeah, that's fine.
Arunbai, yeah, do you want to go ahead? Thank you.
Okay, hello there. So hello there. Very pleased to hear the presentation. Very, very informative. The question I posed earlier, resting heart rate, doctor.
Yeah.
Is that not, people won't know what their resting heart rate is unless they've got one of those activity trackers machines. But what I understand is that the average resting heart rate is a good indicator of how healthy or how strong your heart is.
Yeah.
And And wherever it is, it's a question of actually bringing that down to a level where the heart itself is strong enough to pump and burn, and literally, so whatever activities people are doing, if it's coming down, people will be able to see that it's coming down. And so therefore what they're doing, whatever it is, everyone's metabolism, everyone's stature, everyone's BMI is going to be so different. But if they physically know what their resting heart rate is, then they will get an idea of just how healthy or unhealthy people are.
Yeah.
Am I making sense? Was that, does
Yeah.
that?
Yeah, you're definitely making sense in terms of if you check the heart rates of athletes or people that do a lot of especially mostly cardio exercises, you find that their heart rates can range just between 45 and 60. And for normal people, if they have an heart rate of 45, I'll be a bit worried as a doctor. But if the person tells me they do a lot of exercise, I understand where that's coming from. And if somebody's heart rate is resting at about 90 something, 80 something, and they start getting involved in a lot of exercise, it might start, the resting heart rate might come down a bit. Now, this might be, I do get what you're saying. It might just be a bit more difficult to monitor, in terms of then you have to start chatting it, you have to be mindful of it. So just knowing the fact that a resting heart rate for someone that is very active will be lower, much lower than for someone that is more sedentary. But I do want to mention that many of us can focus on using the scale to measure if we are losing weight. And for some time, during the weight loss journey, the weight loss can keep going up and down, especially when it comes to the scale. It doesn't have to be exactly on the same level or keep dropping in a linear fashion. But measuring oneself, measuring the different parts of the body and keeping a tally of that over the weeks, or just seeing how the clothes fit. So if, let's say, you were a size 16, and then 2 weeks after you've dropped down, 1 month after you've dropped down, that is also a good measure of knowing that you're on the right track. And if you suddenly start going up and your clothes are becoming too tight, clothes that were previously loose, it's also a good measure to see that one is gaining weight. So there are different things that one can use to see that one is not as fit. Like, for instance, there was a time I could do 30 minutes, 1 hour of jogging, and I'm not panting for breath. And then I had a child, I was off exercise for a long time. And then for 5 minutes, I had to literally stop every 30 seconds and just wait to catch my breath. That was a very good evidence that I was not fit. But one can get fit again. It's just a gradual process of just keeping at it, doing the same thing over and over again. And then one builds muscle and builds resilience.
But it's actually knowing, and like you say, charting. A lot of people, if you ask them, what is your BMI or what is your diabetes level, what is this? People don't know. And, since I had my conditions and various things, I'm very much, where am I? If I'm doing okay, then, other things in moderation are fine. But if at any moment in time, I'm out of control, I know my stats are out of control, my readings, my measurements, they're out of control. And therefore, in a sense, then you're heading for the iceberg, your Titanic is going to hit the iceberg. One thing I would suggest to people here, in a sense, is to know their statistics, because it's very much saying, what can I do when you do this? And if it's all very general, then 12 months down the line of any form of diabetes control, very, very few people actually make any difference, because they do not measure, control, literally know where they've started and know where their objective is. 10% of a certain number of people will make any difference after 1 year. And that's, after any diets, any form of courses that people go on, 10%, 90% will carry on as they were, even after all the courses, all the education programs.
Yeah.
And I really do think that people need to wake up to a point that they need to know where they are with certain statistics. They might not like them, but if you don't know where you are, you can't know where you're going.
True. I totally agree with what you're saying, that we have to be take more ownership of our health, more ownership of what is happening to our body. Because at the end of the day, the doctors can only give recommendations. We have to own it. We have to own whatever the issues are. I think we've got somebody with their hand raised. I can't see it anymore. But
yeah, it's me,
yeah.
Sylvia. Just to say about the measuring and so on, I found a good way was attending a slimming club, because a lot of people are, you know, on the same road or journey as you, and you don't feel embarrassed. Well, you do feel embarrassed if you put weight on and you go on the scales, but you know, everybody's in the same boat and there's a bit of camaraderie, and so it's a good way, I think, of just keeping things in check. And even when you've reached your target, you can still attend. I think the membership's free then, within, you know, 3 or 4 pounds of your original weight, you know, target. So I just want to say that, you know, that the slimming club's not, is a very good way of keeping a check on things as well.
Absolutely. I think we can't do this on our own, you see. There is a need for a kind of a group mentality, working together. People, we're not on our own.
Yeah.
And
there's a need for community sense of feeling you belong to a group that can encourage you and all.
Yes,
I do want to mention something though. I know I've used the word diet a lot in my talk. It's something I do try to avoid most times, because when we think that we're being on a diet, it makes us feel we're being deprived of something. Whereas if we think we are making a lifestyle change, we're just changing things around, we're still having the same food we love. So earlier we talked about fried plantain. So instead of frying plantain, why don't you grill the plantain or put it in an air fryer? You're still having the plantain you love. So it is not a diet. It's just, you've just changed the way you cook it to something more calorie friendly and more weight loss friendly. So if we think of the food we're having as a healthier lifestyle, a healthier choice, and not necessarily a diet, it might help our brain in accepting whatever journey we are on.
Absolutely.
Do we have any other questions?
And there's been a couple of comments about walking. Koshika said she likes walking and cooking healthily. On that.
Yeah.
Yeah.
Yeah, I just want to add, it's made a lot of difference in the COVID times. You know, that was one way of self-care for myself, and it's done me really good. And now it's maintaining that same level now. So yeah, it takes a lot of effort, but it's worth it. And of course, the food has got to be healthy as well, so that makes a lot of difference. Thank you.
Yeah, I do totally agree with you. I mean, my journey has been very haphazard personally, and I think that's why I'm very passionate about weight loss and obesity. I've had a child about a year ago, and this has been the most difficult it's been for me to lose weight. I set targets, and then before the end of the day, the target is down the drain, and I settled on the target, and I'm like, why am I finding it this hard? But recognizing the fact that it's a chronic condition makes me understand that, yes, I'm on a long-term journey. I just have to keep resetting the target of checking what is wrong, what can I change, what should I stop? So it's just so we know we are all in this together. The fact that I might not be on the obese spectrum doesn't make me any much different. I'm on the overweight spectrum, and I also still have to keep an eye on things and making sure I don't have any of the health complications. So we're all in this together. We're all having our different struggles at different points.
We have another comment from Deepa Patel. This has been an excellent presentation, really clear and easy to understand. Thank you so much.
Thank you.
And I think another comment that small incremental changes we can all sustain will help us. Having a support group is really helpful. Yeah. I agree with that.
Ask a question for Dr. Sonubi. It was just in connection with the BMI ranges. You spoke about the healthy range. It would be really helpful to maybe understand what that healthy range looks like for, say, for example, Afro-Caribbeans. Certainly, as you were rightly saying in your slide, for South Asians, it's 23 or less.
Yeah.
For white ethnic communities, you know, it's 25. So I wasn't really sure where Afro-Caribbean might sit in there.
So we sit in the same category with the Asians. So if you go on the NHS and BMI calculator
Yeah,
and put
thank
your
you.
BMI, if it falls in 24, it will start flagging that you're at risk of diabetes and all of that, and you need to bring your weight down. So in terms of the LD range, we sit on the same category with the Asians as well.
Thank you. It's a shame actually then that the footnote on that BMI scale doesn't clarify, because I'm sure it just says 23 or less for South Asians. I don't remember seeing Afro-Caribbeans explicitly stated, which is a bit unhelpful, isn't it?
Yeah, I think the first time I realized that was when I calculated my BMI using the NHS calculator. And I think it came up to 24 point something, and it started flagging all sorts of complications to me. I was like, come on, it's within 18.5 to 25 that I'm aware of, because that's all I've been taught in medical school. But apparently, we Blacks and Asians are higher risk of diabetes and hypertension, and that's why it flags that up for us.
It's really interesting actually, because we're actually running a weight management program at the moment for South Asians predominantly. And one of the criteria that we have been asked to work with to bring people onto that group is that their BMI needs to be above 28.
Right.
Obviously, you will agree with us that that's an incorrect statistic to be working with. We should actually be working with 23.
Yeah.
And it's an interesting point, because public health to this day haven't recognized that. So we keep having this same conversation with them. And you're second or third professional now who's, you know, reiterating what's on the BMI NHS website. So
I think it's the problem might be funding, might be the sheer number of people you might have to cope with. If they drop down the criteria to 23 for your program, and then that includes a much higher number of people than if it's 28. So
yeah,
it's probably more of a political standpoint that
yeah, but you know as well, don't you, that if you're outside of that BMI, healthy BMI range, all the comorbidities and all these other risks are much more higher, right? So, you know, we should really be working to a BMI where we're not going to get all these complications. So, as a South Asian, me working towards 25 as BMI is still not great for me, because I'm still at risk of
yeah.
diabetes, blood pressure, all these other things that can happen. So, but I do take your point. I see where you're coming from.
Yeah, it's a bit difficult and it's a challenge, but yeah, I totally agree with you. And I just feel if there's political will, if there's more funding to tackle obesity, then we'll at the same time be tackling diabetes, tackling hypertension, tackling a lot of other things, and we'll
Exactly.
probably spend less money on all the other chronic conditions. But unfortunately, this is what it is. We are treating the complication of the obesity and not really treating the obesity itself.
Thank you. Thank you for that.
Yeah, you're welcome.
Yeah, there's some more comments about an informative session, and thanking us for organising it. Then there's some comments about the need for a Northampton group to start. To start with this weight management project. So yeah, I think we need to kind of look into that. Probably work with public health and NHS into developing something for Northampton, really, and get things going. I know there's Deepa, you mentioned there's one for South Asians. I mean, what does that entail?
Right, so we've just launched, actually. We're just going into week 2 of a 12-week structured weight management program. So what that does is it's a series of educational talks, but that's overlaid with the sort of motivation and support of going on to physical activities. So that's Zoom, face-to-face, very much pick and mix. You know, you choose your level anything from chair exercise to, you know, yoga exercise to all sorts of different things that you can do, walk and talk. So it's very flexible in how you do it. And then on top of that, we overlay that with some daily challenges. So every day I kind of send a sheet of daily challenges, and they're really small things like eat 1 piece of toast today instead of 2, you know, and have a glass of water before you have a meal. Try to, you know, walk up the stairs 3 times rather than twice. So very, very slowly building up that physical activity level to improve your heart, as Aaron was saying earlier. So yes, we're going into week 2. We just recognise that again, that the kind of main offerings from GP surgeries for weight loss in terms of diabetes and things just weren't culturally aligned. So we've come up with a programme that very much supports our culture, really. So anyone on this session, I think there are some who are already part of that group, but if you wanted to join, get in touch with me. But yeah, that's what we've done. So I guess that's the kind of thing that you may want to think about doing as well, you know, where it talks about your diet, what kind of foods do you know, what do your communities align to, you know, telling Asians, you know, to eat chicken and turkey, whatever, that's not our diet. So even the fundamentals of our diet don't align to what the main kind of offerings are. So we've pared that down to, okay, so what flour should we use for chapati making? What oil should we use for making curries? You know, how should we measure that oil? So really small things, but actually very valid to our communities rather than something generic that's alien that people just won't listen to.
We have a comment from Pratima Ben. We can raise this with Public Health Bayan. Power of the Mind is running one for African Caribbean communities. If we check with Mavis, so that there is a group there. Yeah.
Yeah, I'll get some more information and pass it on to Joanne and anyone else who is interested. Our contact details are actually on the leaflet itself, on the leaflet that was advertised. So we can share that, certainly.
I think we've got a comment from Punima Ben, Jani. Thanks to Deepa Ben and Kaushika Ben and the team for organizing this. It's been organized by United African Association, and we are helping them. You know, we are sort of sharing on Ashadeep events as well. So I think thank you to both the teams for making an effort, you know, members coming in and joining us today.
Absolutely. This is part of like it's part of a community champions project in which there are 2 organizations, mainly United African Association and Ashadeep. So United African Association kind of looks after the African and African Caribbean communities in Northamptonshire, and Ashadeep looks after the Asian communities. So we've got a current project that's concentrated on COVID safety. So it's about encouraging people to take their vaccines, still encouraging COVID safe lifestyle, as in mask, hands, space. So we are doing that. We're also looking after people with, supporting people with long COVID. And we're also getting people who are unregistered to be registered with GPs. And that's particularly the case for undocumented migrants. So we're still working on that project as well. And that's a current project that's been supported by Public Health and is, so we're under the umbrella of Public Health doing this Community Champions project, basically getting people safe, getting some vaccines set up in Northamptonshire. And we've got our next vaccine at the mosque in Northampton on Friday, and are encouraging people to come. And it's not just about the COVID vaccine, there's going to be flu jabs, there's going to be LFT testing, and there's going to be community conversations about how people keep safe, and just encouraging everybody to keep safe, especially in these very difficult times. So we really do thank you. If anybody wants to make any more comments, I think we might be finishing.
We have a lovely comment from Sylvia. Excellent presentation and information. She felt the doctor was speaking from knowledge and experience. Doctor, that's for you, son. Dr. Sonubi.
Thank you.
Thank you. Has anybody got any more comments? Otherwise, we may close the session a few minutes early, but it's been absolutely fantastic. It's been really, really good, very informative.
Thank you so much. It's been brilliant. Thank you.
Thank you so much, Dr. Sonubi. It's been excellent.
Thank you. I think we're going to close the session here. Thank you, everybody, for joining us today. We are going to be holding another session, more sessions in January on other health conditions. We've had diabetes, sickle cell, fibroids so far. We did miss out on the prostate cancer, but we hope that will come. The session will be held in January. And there's autism to come up. There's heart conditions, diabetes. No, not diabetes, sorry. High blood pressure as well, and other health conditions that affect the African, Caribbean, and the Asian communities in which we live. Thank you very much, everyone, for joining us, and have a good night.
Thank you.
Thank you.
Thank you, everyone. Bye-bye. Stay safe, everybody.
Bye. Bye-bye.